Hi, everyone. I'm Alan Lebrique, Director of the JHU Global mHealth Initiative. I'm an Associate Professor in the Department of International Health here at the Bloomberg School of Public Health. It's my pleasure to be here today to talk to you about digital and mobile health. Today, what I'm going to do is give you an overview of this new emerging space of health innovation and talk a little bit about the challenges of moving from pilots to sustainable large-scale impact. So why are we here? Why are we talking about digital health in a school of public health? Well, frankly, it's summed up very nicely in this one figure. Over the past decade, we've seen a mobile phone revolution happen in the populations in which we work across the world. There are today nearly as many mobile phone subscriptions as there are human beings on this planet. This new reality of over 7 billion mobile phone subscriptions, this is data from 2013, so now we've actually surpassed the point where people actually have more phones than there are human beings. This new reality presents itself as an opportunity for those of us in global health. And the opportunity is that we now can reach populations in places which were considered to be the last mile, the hardest to reach areas of the globe, where we struggled to get interventions that we know were life-saving and efficacious to the populations that needed it the most. Access to information for many decades has been the privilege of the few elite members of society. But this reality has been transformed by the mobile revolution, providing access to resources such as the internet, but also timely, appropriate messages to pregnant women, to individuals living with HIV/AIDS, to those who are trying to treat complex diseases like tuberculosis, or even stopping smoking. The mobile phone now has become part of daily life in many corners of the world, even where maybe 5 or 6 years ago, we would have been surprised to see a phone in the hands of a farmer or a community village worker. In rural Bangladesh, where I've had the privilege of working for over 15 years, mobile phones penetration has increased to over 100%, where it's not just the man of the house owning the phone, but often the wife and other members of the family also having access to these potentially health transformative devices. We are, after all, in global health, impatient optimists. And the Bill and Melinda Gates Foundation likes to use this saying as the title of their blog, which they publish. But what does this mean? It means that we want change to happen faster than it might happen in its natural state. What we're trying to do as global health practitioners is to reach that goal of global health, of universal health care for families, even in the most remote parts of the world. Families that may be removed from the health systems that are supposed to be serving them, or families who live at the last mile, distanced either by socioeconomic statuses or simply geographic obstacles. To me, this picture represents really the summation of why we do what we do. This inside of a Boeing 747 represents today the number of pregnant women and new mothers who die on a bi-weekly basis in most countries in South Asia. This urgent crisis that's driving us to implement the public health strategies that we know can save lives more effectively and across a broader swath of populations than we currently are able to reach. But changing health systems is difficult. I like to use this picture to illustrate the struggle that sometimes it is to move the status quo in countries where things have been a certain way for decades, if not centuries, pushing health systems that have been established a certain way to think creatively, to identify pain points and obstacles, and to move beyond the way that we've been doing things traditionally. I think it's important to note this urgency because every minute we lose one woman or girl in pregnancy or childbirth, most of these deaths are avertible. And so the onus is really on us to leverage all these possible technologies to try to accelerate the reach and quality of the health programs that we have developed in this public health arena. So what are we talking about here in public health? Well, innovation is a combination of a number of questions. The first question is always, what is the problem we're trying to solve? What is the public health constraint that is preventing us from reaching the appropriate number of people or improving the quality of the services that we're providing in a particular population? What do the end users want? What is the expectation of the population we're working within? What's possible given the ecosystem and infrastructural context in which we work? Providing smartphones in a context where there aren't high-speed networks available may not be the most optimal use of resources. And then what is viable? What can survive the longest possible time given these other ecosystem pressures that we think about? That, ladies and gentlemen, is real innovation, where we are looking at solving problems in new ways within the context that we're presented, but also aligned with the priorities of the populations we work within. We often come face to face with innovators who are so disruptive, they are disruptively disrupting other disruptors. And I think we sometimes face this issue of folks who have lost sight of the problem and have been enchanted by the innovation for innovation's sake. I think in public health, we have to take a very strong position in terms of aligning the innovations with the problems and the needs of the populations we're trying to serve, specifically because we work in low resource settings. So the availability of resources is often the constraint under which we operate, and the onus of making sure we allocate those resources smartly is on us. I think the other sort of emergent questions that should be considered when we think about innovation for development is not just the 4 questions I posed to you a minute ago, but it's also important to think about what can we scale and what can we sustain over the long term. So scalability is more than just a feature of the technology itself. It has to do with what the ecosystem around that technology is able to support. And that also ties into this question of sustainability, which thinks about over the long run, can we have true local ownership of this technology or this innovation so that the reliance on the external agents who might be operating in that environment, Hopkins as an example, are not the rate limiting step to transferring that technology to that local population? So I love this figure because it really highlights how quickly we tend to get distracted by shiny new objects. And in order for us to reach scale and achieve real change with technology, we have to stay focused on the priorities and not get distracted by every shiny new, look, squirrel object that comes our way. And I think technology moves so fast that very often there is this temptation to look at emerging new technologies consistently. But really sometimes solving those problems that we've identified requires simple, appropriate solutions that can be deployed, scaled, and sustained in the context in which we work. So let me give you some examples of how technology, specifically mobile technology, has been used to respond to crisis. One example that might be familiar to many of you is the 2010 earthquake that happened in Haiti was one of the earliest examples of the use of mobile devices in response to a massive humanitarian disaster. Very, very rapidly, a global health community, and this National Geographic article, I think, illustrates it very elegantly. A global health community came together around broadcasting messages to all mobile phone clients who might have been trapped or affected somehow by this earthquake, and then collected free text data through text messaging from these individuals, and were not only able to triage the different problems that were being felt by the community in a very urgent way, but also pinpoint these urgent reports geospatially on a map, allowing resources to be targeted to where they were needed the most. A few years before that, a massive earthquake in Sichuan, China, was also an example where mobile technologies were used for infectious disease surveillance during and after the earthquake, where the public health agencies provided reporters, key reporters within the community, with mobile phones that were solar charged, allowing them to submit information reports using these mobile networks, even after this terrible disaster. Our colleagues at the Harvard School of Public Health have been doing some very interesting modeling exercises using simply the mobility of phone users as they transfer from one cell tower to the next to develop these exciting maps of how populations move in West Africa, an exciting way of visualizing how populations are dynamic and potentially can spread infectious diseases across these channels of movement that you see across West Africa as they move from the coastal regions to inland communities. And so mobile phones not only providing us a way of collecting information actively, but also passively, as this example suggests. So health systems are inherently complex, and recently we published a framework that's illustrated here that's based loosely on the 1970s Tanahashi model that some of you may be familiar with, that tries to deconstruct the complexity of a health system across these 5 major axes: accountability, supply, demand, quality, and cost. And to reach that goal of universal, effective health care that we talk about so often, illustrated by this bar on the right, we need to achieve better performance in each of these domains and subdomains in order to get to that right-hand goal. So whether that's improving the affordability of services, the accessibility or availability of human resources, to know the denominator to whom we are supposed to be providing these services is something that mobile telephony has been able to strengthen in health systems that we work in. So I'm not saying here that mobile phones are the panacea or solution to all of these challenges, but certainly they may play a role to incrementally improve some of the challenges that we face in any one of these verticals. One of my favorites here is the 4th bar from the bottom, the availability of commodities and equipment. Using mobile phones for field pharmacists to report stockouts has been one of the most exciting ways in which phones have been used to make sure that vital drugs and supplies don't run out when they're needed the most by members of that community. And so again, we see how a simple innovation in information or communication can be transformative in the functionality of a health system. But it's important to keep in mind that mHealth doesn't work in a vacuum. It's not by giving a phone to a health worker that suddenly all of these challenges that I just described will evaporate. In fact, it's important to take a systems approach, to understand that the mobile technology is part of a complex system of solutions that involves transportation, that involves the availability of liquid assets to pay for goods and services, skilled and available staff in the facilities when facility-based care is needed the most. And then on the bottom left here, I've depicted data use, which is often the neglected pillar of a systems approach, which is once we collect all of this information, how are we actively using this data to improve how we deliver goods and services to a community in a low resource and potentially remote setting? I think that is another important consideration when we think of this potential vacuum approach to problem solving. As I mentioned earlier, the draw of being attracted to shiny new objects is very strong. But in fact, we have to keep in mind that mHealth fundamentally is not about the technology. It's about asking how this technology can improve the quality or efficiency of something that we already know works. By and large, we have hundreds of interventions that have been tested and shown to be efficacious in global health, whether these target neonatal survival, child health, maternal health. These interventions have been put through the gristmill of evidence and found to be efficacious and now are recommended by global health agencies. The challenge, however, is in getting these interventions to the level of coverage and quality, frankly, where they reach the maximum number of people who could benefit from those goods and services. Along the way of this trajectory to effective coverage, we run into a number of problems. And again, you see this emphasis on the problem. Failure to follow guidelines, drug stockouts, lack of performance training. There are dozens of other challenges or potholes in this highway to success. And so you must think about digital health or mHealth strategies as a way of filling these potholes or these gaps in that trajectory, allowing us to achieve that goal of high quality, effective coverage in the populations where it's needed the most. So the question we ask ourselves really isn't, does mHealth work? It's really, does mHealth optimize that which we already know works? And I think when you shift your thinking to the second question, it opens up your thought process to a very different approach to thinking about digital health and mHealth. As an example, here we have a matrix of potential health system constraints that are articulated across 7 different axes, from information to cost, that you can actually use as a template to identify the sticking point or the pain point in the delivery of your particular program. Are you having a challenge of maintaining high quality of care or health worker competence? Is the challenge in this particular program poor adherence to treatments or timeliness of care? Depending on what the problem you're trying to solve is, the solution can be very, very different. It may include a strong digital health component, but it may also include a strong training component or a strong financial component that helps to optimize and overcome that challenge that you're trying to solve. In these few years where digital health has become now, I will say, almost a household word, we really have been through a number of eras. And I think in a short time of a decade, we've seen this global community, this ecosystem, move from one of multiple projects trying similar strategies, innovation and experimentation, to what I call discordant proliferation. So many projects scaling up to different levels of implementation, but often not speaking to one another, not learning from each other's mistakes and each other's successes. In the past 5 years, we've especially entered into this domain where health agencies and funders specifically have started to ask very strong questions about the value of their investments and what do the implementers have to show for the strategies that they've been supporting. And so this period of scrutiny and consolidation has led to what I would say we've entered in the past couple of years, which is really a period of integration and scale, where governments and large-scale implementing agencies have begun to seriously consider digital health solutions and integrate digital health solutions into the normal way of delivering health interventions in populations they serve around the world.